Hi everyone, welcome back to my channel. Today we're going to talk about the DSM-5s. I'm going to do a series where I'm breaking down the DSM-5 based on the categorical orders. So I wanted to start with depressive disorders today. So in this video we're going to break down the diagnostic criteria. We're going to talk about the assessment, the tools, the treatment modalities, the medications, the techniques, treatment planning, and then we're also going to talk about the ethical considerations every clinician must keep in mind. And before you start diagnosing yourself, stop right there, okay? Because I'm going to tell you something right now. When it comes to depressive disorders, the DSM does not care if you are tired of your boss. This is really about what constitutes what is depression and the specific types. All right, so basically, depressive disorders are more than just feeling sad, okay? It's a persistent mood disturbance that affects your emotions. It affects your thoughts, how you function physically. So when you have a client that presents with depression, they often will say things or use words like hopelessness, poor concentration, fatigue, changes in their sleep or appetite, and they have an impairment in their daily functioning. So this ain't just, how can I explain this? This is just not like being in your feelings for a weekend. It's not like a Drake song. This is when sadness moves into your life, set up Wi-Fi, and starts paying rent in your life, in your brain for free, okay? So one key thing to note about depression is duration and impact. This is what separates clinical depression from everyday sadness. I'm going to say this again. Duration and impact is what separates clinical depression from everyday sadness, okay? So it's like a spectrum of conditions that is clinically significant to mood regulation, okay? So it basically causes a functional impairment across different domains in your life, like how you perform at work, how you do in school, your interpersonal relationship. So it looks different for everyone, but it's consistent in how it affects your neural processes, if I'm making sense. So now the umbrella includes depressive disorders, has an umbrella that includes major depressive disorder, MDD, persistent depressive disorder, what they used to call dysthymia, but they changed the name to PDD. Then they have disruptive mood dysregulation disorder, which is only specifically for children. And then they have premenstrual dysphoric disorder, and all other categories of other specified and unspecified. Every one of these that I just listed has its unique criteria, but they all cause clinically significant impairment. So basically, in other words, the DSM says we got depression in different flavors. Some of them are short, some of them are long, some of them are moody kids, hormonal cycles, and some of them are we just don't know yet, but it still is depression or it's looking like depression. So let's talk about major depressive disorder. Major depressive disorders requires at least 2 weeks of symptoms. Let me repeat that again. At least 2 weeks of symptoms, and one must be a depressed mood or anhedonia. Anhedonia just basically means a functional impairment, like it's stopping you from doing things. So I want you to remember this mnemonic, SIG-E CAPS. The mnemonic SIG-E CAPS encapsulates the core symptoms of major depressive disorders. So you have sleep disturbance, interest loss, guilt, energy decrease, concentration problems, appetite changes, psychomotor changes, and suicidality. Okay, if you remember, SIG-E CAPS for sleep disturbance, interest loss, guilt, energy decrease, concentration problems, appetite changes, psychomotor changes, and suicidality, then you know those are the symptoms that are needed for a MDD diagnosis. Okay? So remember, for major depressive disorder is more than just being like Garfield, someone who just hate Mondays. Okay? You need a consistent pattern. Okay? Not just Sunday night dread. Okay? You need a consistent pattern of having SIG ECAPs: sleep disturbance, interest loss, guilt, energy decrease, and concentration problems, appetite changes, psychomotor changes, and suicidality. And I'm repeating it because this is what you need to know. So if you have a client, before I use that example, let's talk about the differentials. The differentials diagnosis is what you need to rule out because major depressive disorder can look at other things, right? So in major depressive disorder, some of the differential diagnosis is bipolar, grief, substance-induced, or medical conditions, okay? So if you have a client that tells you, I haven't slept because I'm building a business empire at 2 a.m., don't call that depression, okay? You have to check for mania, because if it's mania, then you know that, hey, that person is not depressed. That is classic case bipolar disorder. And then when you think about treatment approaches, remember my treatment planning video when we talked about different diagnosis requires different treatment. So for MDD, the treatment approach that is gold standard that you can use is cognitive behavioral, IPT therapy, which is interpersonal therapy, which is the strongest. Those two are the gold standards. Then you have DBT therapy and group therapy to help give them emotional regulation and social connection. Okay? So that is one of the treatment modality approaches that you can use if you have a client with MDD. Also, when it comes to medication or pharmacotherapy, they mostly prescribe SSRIs. They prescribe antidepressant, and the type of antidepressant is SSR, which stands for serotonin selective reuptake intake. Okay, so which that basically means that is when an individual is typically depressed with like major depressive, a psychiatrist or a medical doctor will prescribe them an SSR. And SSRs are basically it's like the Starbucks of antidepressants. So it's just like you have to prove that you need an antidepressant. I hope I'm making sense. All right. And then when you think about the safety and ethics of an individual with MDD, you have to constantly maintain ongoing suicide risk assessment and implement a safety plan, especially if they have suicidal ideation. And then you always have to balance confidentiality with duty to warn. But also, therapists, make sure you also understand the cultural implications that come with it, because you have some different cultures that do not necessarily feel like depression, they don't necessarily take depression seriously, if I'm making sense. Like, for example, West Indian or Caribbean cultures. And then informed care is an essential component to major depressive disorder, because when you have a client, they may need medication, so you might have to have informed consent so you can basically help plan better treatment with their physician. Okay, now we're going to get into persistent depressive disorder. This used to be called dysthymia. So now, remember, major depressive disorder is at least 2 weeks, right? Dysthymia is having a chronic low-grade depression lasting at least 2 years in adults, and in children and adolescents, at least 1 year, okay? So clients who typically have this, they're persistently sad, if I'm making sense. And they are not symptom free for more than 2 months during the sadness. It's like a chronic low grade sadness, okay? So I like to use an example. So a perfect example of someone that has persistent depressive disorder, dysthymia, will be Wednesday Addams, right? Because she always have a gloomy baseline, or Daria from MTV, Daria. That yes, I'm showing you my age. If you don't know, go look it up, go watch a clip on YouTube. So, and when you think about treatment for this particular disorder, treatment is long term, okay? So when you are doing therapy, the modality you would want to use is CBT, psychodynamic therapy, and SSRIs, just like major depressive disorders. SSRIs medication helps with improvement, right? So this type of disorder is not a quick 6-session and you're cured situation. No, it's more like they would be in therapy like a gym membership, because they have to commit for the long haul, because this is like a chronic type of depression, and you have to really give them realistic goal setting because of how impaired their quality of life is. All right, and you have to help your clients. You have to help your clients learn or gain long-term coping skills, and help them cognitively restructure their thoughts. Okay, and then when it comes to ethics for this particular diagnosis, you have to help address chronic illness stigma and help them maintain hope while giving them, prognosis information, like what is it called when you give them psychodynamic teaching, when you give them like the pamphlets and stuff to help them know and understand their symptoms. Okay, so for this particular disorder, you want to focus on long-term management rather than acute symptom relief. Okay, and depending on a client and their needs, family therapy will help address the systematic factors that contribute to their chronic depression. Just like Wednesday Addams, like she's constantly gloomy, but she always feel like the source of her issues is like the dynamics between her brother and her father and her mother, if that makes sense, or her family. Next, we're going to talk about Disruptive Mood Dysregulation Disorder, DMDD. This particular disorder is only for children and adolescents before age 10. So this is like a recurrent temper outburst, and it's like an irritable baseline mood. Think about the kid that's constantly crashing out. So it's not just a bad kid, it's just like every day this kid is on like death count 1 meltdown. Like, I have a background in the classroom, so if you have teaching experience or if you hear horror stories, there's a lot of them on TikTok, and you hear about those, like a specific child that's constantly like crashing out and nothing seems to trigger them, then you may want to consider DMDD. Now, when you're thinking about differentials, you have to rule out pediatric bipolar. DMDD was actually created because bipolar is like an adult diagnosis, and they created it to not keep over diagnosing children with bipolar disorder. Okay, so if you call it bipolar too quick, you're gonna have a parent Googling mood stabilizers, when really for this particular disorder, a child really needs structure and therapy. Structure and therapy, and maybe an ABA therapist. But anyway, so the treatment planning for this will be parent training, teaching parents how to maintain structure in their home, how to set boundaries with their child, to their child. CBT therapy is excellent, gold standard family therapy, and medication is only case by case, right? So the real MVP in this treatment framework when working with this type of case is parent coaching. No pill is going to fix bedtime chaos if the house doesn't have any structure or boundaries, if I'm making sense, okay? And then for the ethical consideration, you have to have guardian consent for all interventions concerning this particular client because they are underage. Remember, for this particular diagnosis, you may have to do mandatory reporting protocols if it's like any thoughts of abuse or harm. And then you have to also be aware of cultural sensitivity regarding discipline practices, especially when it comes to children and that dynamic, okay? And how they assess this is usually with like parent-teacher behavior reports, standardized behavior rating scales, and clinical interviews with people that basically, interacts or have a relationship with this particular child and their developmental history and a timeline, okay? Our next disorder would be Premenstrual Dysphoric Disorder, also known as PMDD. This disorder tracks with the menstrual cycle, and its symptom starts in the luteal phase and it resolves after menses. So this particular depressive disorder, PMDD, is severe and it's impairing. So I just want to make this clear. It's not PMS. It's like PMDD is like PMS, but on steroids. It's like I hate everyone, even the cat, for like 2 weeks straight, right? And the diagnosis requires prospective daily ratings across 2 cycles. And the treatment for this particular disorder includes CBT, lifestyle interventions, and SSRIs, sometimes only medication during the luteal phase, if that makes sense. And for this phase, you have to consider informed consent to discuss like reproductive consideration for medication and stigma around it. Now, when you see other specified or unspecified depressive disorder, those are just flexible categories. You use them when symptoms are impairing, but they don't meet the full criteria. Basically, that's just the DSM-5 way of saying we know something is wrong, but we don't have a cute label for it. Like, I know something is wrong with you, but I don't really know why. I just know that you're depressed. So you use other specified depressive disorders when the symptom causes clinically significant impairment, but it doesn't meet the full criteria for any other of those depressive disorder. So it's like the clinician specifies the reason, whether it's short-term depressive episode or it's a depressive episode with insufficient symptoms. An unspecified depressive disorder apply when symptoms cause significant distress or impairment, but the clinician chooses not to specify why the criteria is not met for the other disorders. This is often used in emergency settings or when there's not enough information available. And the ethical issue with this is you have to be careful in your documentation and you have to justify the diagnosis and the treatment. And you have to avoid overuse of the catch-all categories. And you have to constantly give regular assessments to refine the diagnosis as more information becomes available. And when you consider the treatment for other specified or unspecified disorder, the treatment approaches are minor because it's based on symptoms and the severity. So what you would do is give supportive psychotherapy, CBT techniques as it is appropriate, and lifestyle interventions. Tell them like to have like a catharsis, a release, to run, exercise. And if the impairment is very significant, you can, we can't prescribe, but medical professionals can prescribe antidepressants in the form of SSR. Okay, so this is like a clinical judgment that's flexible, and it helps to rule out other depressive disorder and adjustment disorder and medical causes. So what you would need is like a detailed clinical interview, a functional impairment assessment, and symptom severity. So these categories, other specified and unspecified disorders, I know I'm just repeating myself right now because I really want you to understand that they are flexible in clinical practice, while they maintain diagnosis precision, they should only be used when they know something is impairing, but it doesn't meet the full criteria of the other disorders that we discussed. Now, overall, when it comes to safety planning across depressive disorder, that's very essential because you as a clinician needs to identify the warning signs. You have to teach them coping skills. You have to know, or they have to tell you people, their support system, safe people. You have to remove lethal means if they like harm themselves, cut themselves, things like that. And then you have to provide them crisis line information like 988, the suicide hotline number. So this is not optional. So if your client tells you that they're Googling ways to die, you don't just say, see you next week. No, boo-boo. You pull out that safety plan. Pulling out that safety plan is essential. So it is your duty, counselor, to identify the warning signs. You have to collaborate with your patients to recognize their personal warning signs of suicidal thinkings. You have to ask them specific thoughts, feelings, and behaviors that may indicate that they have an increased risk. And then you have to help them develop healthy coping strategies. You have to help them create a toolbox, a toolkit of internal coping skills that they can use independently, such as mindfulness techniques, writing, physical activities, or cognitive restructuring thoughts, or deep breathing exercises. And then you have to ensure that they can identify, or you help them identify, support networks like family members, friends, or any individual who can provide them some type of distraction and emotional support during their crisis situation. Because let's be honest, you're always not going to be available, so they need to have a safety plan. And in that safety plan, you have to include their support networks. And then you have to help them establish clear protocols for contacting mental health professionals during after hours. That's supposed to be, and that needs to be in your informed consent, right? When you need to tell them, if I'm not available, this is who that you call. So you need to give them 988, the suicide hotline number, national crisis, whatever it is that they need, and you give them the specific instructions for when to reach out, okay? And then not only that, you have to collaborate with them on removing or restriction access to lethal means. Even that may mean included medication. Believe it or not, some of them may have plans to overdose firearms if they have that, or they have access to those things, or anything that potentially can harm them, or even in some case harm others from their immediate environment. So a well-constructed safety plan is a collaborative document that you would work on with anyone in this umbrella of disorder that's going to help empower them and create concrete steps that they can take when they are having moments of crisis. And this helps to bridge the gap between suicidal ideation and professional intervention. Now, when you're dealing with any client in this umbrella, you have to balance confidentiality with safety. So that means tear-soft duty, mandated reporting, informed consent, cultural competence. These are all non-negotiable. And please, please, please don't be the therapist who says, I didn't want to break confidentiality while your client is in crisis. Protect your license and protect your client. Remember, you have a duty to warn and protect. So that's the only time you will break confidentiality, when they pose an imminent danger to themselves or someone else, okay? And you have to document the decision-making process and consultation with your colleagues or supervisor when you have a complex situation such as that. And remember, mandated reporting is your legal obligation to report suspected child or elder abuse. And when you mandate report, there's no confidentiality in that. You have to report that. So you have to familiarize yourself with your state-specific reporting requirements and the timelines for appropriate compliance. I know in my state in Florida, specific careers like teachers, medical doctors, nurses, and stuff, like we are mandated reporters. So even if a child or someone doesn't say nothing, if we suspect anything, we have to report. Same thing with you, clinician. If you suspect or a client says something that alludes to abuse of a child or adult elder, you have to report. And then you have to balance confidentiality. You have to navigate the tension between maintaining therapeutic confidentiality and ensuring patient safety. So it's a balancing act. You have to know when to protect confidentiality if it's therapeutic, but when to ensure its safety. So if a client is showing instance where it's going to be a breach in safety, baby, that's when it is your responsibility to breach that confidentiality, and you must involve your patient in the safety planning process, right? Because when you do that, you meet legal and ethical obligations. And then, counselor, I don't want you guys to downplay how significant cultural competency is, because every cultural, linguistic, and socioeconomic and spiritual aspect influence how depression is presented and how it's being treated. So you have to adapt their approaches and integrate it respectfully, but you also have to maintain evidence-based practice. And when it comes to informed consent, and I know I keep saying that because that's important, because when you're working with clients that present with depression, oftentimes they may or may not be on medication. So you're going to need informed consent for both therapy and medication, including discussions of the benefits, the risks, alternatives, and the limitations of those things. So you have to address those capacity issues in severely depressed patients, and you must do it appropriately. So those are the legal and ethical approaches to dealing with individuals with depression. Now, I'm just going to give a recap, right? And you can say it with me. Major Depressive Disorder, MDD, is how many weeks? Let me hear it. If you said 2 weeks, clock it. PDD, Persistent Depressive Disorder, aka Dysthymia, they don't call it that no more. It's just important to know. The duration is how long? How many? Weeks or years? If you said 2 years, clock it. DMDD is what? It's childhood what? Irritability. If you said that, clock it. And PMDD is tied to what? You better not say PMS. Is PMS on steroids? Yes, it is. It's tied to the menstrual cycle. Clock it. And the gold standard for majority of these disorders is what? CBT, right? And what else? What type of medication? Antidepressants are in what medication class? SSRIs. Clock it if you said that. But the treatment must always be individualized, and across all cases, assessment, safety, ethics, and cultural awareness is essential. So I'm going to wrap this up and I'm going to say it again. MDD is 2 weeks. PDD is 2 years. DMDD is for kids. PMDD is tied to the menstrual cycle. Gold standard is CBT, SSRIs, with safety and ethics always on your radar. Think of it like this. Therapy is the driver, medication is the gas, and safety is the seat belt. All right, that's it for today's video. You got depressive disorder umbrella in like 30 minutes or maybe less, who knows. I know depressive disorders are heavy, but you just leveled up your knowledge. If you find this video helpful, like, comment, and subscribe. Tell me in the comments which disorder stresses you most for the exam, and then we'll break it down together. And remember, for this particular disorder, recovery is possible, hope is therapeutic, and your skills, the skills that you have, because you have it in you to be an amazing counselor, can transform lives. Now go flex your DSM knowledge and the clinical knowledge that you just gained. You a clinical baddie. Clock it. You go, girl.